Assalamualaikum. Boleh melekat sorry lambat.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can you guys hear me?
Yes.
Dengar? Okay. Thank you. My name is Tina Izzat binti Muhammad Nur Hadi and I will present about bronchial asthma. Before we go further, let's look at the definition first. Next slide. Okay, based on PEAK protocol 4th edition, the definition of asthma is chronic airway inflammation leading to increased airway responsiveness that led to recurrent episodes of wheezing, breathlessness, chest tightness, and also coughing, particularly at night or early in the morning. It is often associated with widespread but variable airflow obstruction that is often reversible. Okay, next slide. For epidemiology, bronchial asthma is the most common chronic respiratory disorder in childhood, and the prevalence is higher in boys compared to girls with 2:1 ratio male to female. Other than that, in Malaysia, we can conclude that Malay has the highest prevalence compared to other ethnicities with percentage of 8.1, followed by Chinese 7.4% and India 4.3%. Next slide. This is the etiology of bronchial asthma. It is divided into two, which is extrinsic and also intrinsic. In extrinsic, we have allergens such as dust mite, animal whisper, perfume, pollen, and mold. And then we have environment, which either the patient lives in industrial area or living in with family who is smoking, having carpet in the house, and also pollen. And then infection, cold weather, exercise, emotional expressions such as laugh and cry, and then drug-induced use such as aspirin and also beta blocker, and also food or chemical irritants. For intrinsic, it is genetic factors. There is no specific trigger for intrinsic asthma. And then the incidence for intrinsic asthma is higher in child when there is first degree relatives who are asthmatic. Next slide. This is the brief pathophysiology for bronchial asthma. When there is triggering factors, it will lead to bronchial inflammation, which is you're having mucosal edema and produce excessive mucus, and then lead to bronchial hyporesponsiveness and also bronchoconstriction that makes the airway narrow and lead to symptoms such as wheeze, cough, breathlessness, and also chest tightness. Next slide. Okay, as I said before, this pathophysiology will lead to the clinical features, which is wheeze, chest tightness, cough, and also breathlessness. Next slide. Okay, for history taking, we started with describe the symptoms, the onset of the symptoms, pattern, and also associated symptoms. Does the symptom is recurrent? Because patient with bronchial asthma usually it is recurrent and episodic and also occur at daytime. And the cough will occur at night or early in the morning. Then we need to know the triggering factor for the patient, as I mentioned in the etiology earlier. Not only that, the wrong usage technique of the inhaler also can be the triggering factor also. And then the severity, we can ask if the child is already went to school or not. If yes, we can ask how many times the child missed the school due to the condition, or we can ask about the limitation in the child activity, such as the symptom occur at rest or on exertion, or maybe we can ask um, during the attack, the patient can stop in praises or words. These things we will discuss later about the 9 components of severity of asthma later. Other than that, we need to ask the risk factor for this patient. Maybe we can ask about the atopy, such as um, eczema, allergic rhinitis, conjunctivitis, and also we can ask if there is some history of asthma. And then if the patient is already diagnosed with asthma, we need to clarify the diagnosis. When was the diagnosis made? The presentation during the diagnosis. What is what the investigation that has been done? Previous exacerbation, which is previous hospitalization, current treatment, and also control of the disease. Next slide. So this is evaluation for asthma control. We can know either the patient is either the asthma is controlled or not by evaluate the daytime symptoms, limitation of activity, nocturnal symptoms, um, uh, need reliever or not, and also lung function test and exacerbation. Okay, next slide. Uh, for physical examination, based on inspection, we can see the patient will have respiratory distress, um, either with cyanosis or not, or maybe we can see pushing features because patient with prolonged usage of corticosteroids can have pushing features, and then patient having eczema due to having atopy symptoms. And then we can see hyperinflated chest and also Harrison sulcus. Harrison sulcus is an indentation on the chest roughly along the sixth rib, which is actually bilateral but can also occur unilaterally. And then on palpation, the chest expansion and vocal parameters will reduce. And then on percussion, it will give hyperresonance. And then for auscultation, we can hear vesicular breathing with prolonged expiratory phase, reduced air entry, and also generalized expiratory bronchi. Next slide. So this is the uh, pictures of Harrison sulcus and other uh, chest abnormalities. Okay, next slide. Okay, the differential diagnosis for asthma is bronchiolitis. This topic will be discussed in later by Sisenisa. Both of bronchiolitis and asthma have this similar sign and symptom. However, in patients with bronchiolitis, usually having fever and also chorizal symptoms, which is runny nose, nasal congestion, and also cough. And then next, differential diagnosis is inhaled foreign body. This is common among children within 6 to 8 months because they started to know how to read and grab objects and put in their mouth. So maybe they're having foreign the foreign body is going into their respiratory system. And then next, cystic fibrosis. It is a chronic respiratory disease that can mimic asthma symptoms. However, for cystic fibrosis, it will associate with other organs such as GI system. And then pneumonia. Pneumonia is presented by brother Dennis, but pneumonia, we can hear dullness on percussion, which is contraindicated in asthma, with having hyperresonance on percussion. Patient also will present with coryza and symptoms and fever. However, pneumonia also can be the triggering factor for exacerbation of asthma. And then vocal cord dysfunction. Okay, next slide. Um, the diagnosis of asthma is based on a good history and physical examination. Investigations are not usually necessary, but to diagnose um, asthma, we can do spirometry test. With, with, sorry. Okay, for lung function test, we have peak expiratory. We can do peak expiratory flow rate by using peak flow meter. It is we can use this for patients 5 years and above because patients below 5 years cannot do cannot perform it well. They cannot hear our apa arahan. And then it is less reliable than spirometry. And then spirometry, it is to confirm asthmatic to because it can divide. We can know either the respiratory disease is either the patient having obstructive or restrictive respiratory disease. For asthma, it is obstructive respiratory disease. It also used to monitor the response, used to monitor and the severity, the monitor the response to the treatment and also to measure the severity of exacerbation. Usually, the FEV1 to SPC ratio is less than 80% in asthmatic patients. Next, for bronchodilator reversibility test, asthmatic patient will improve after a dose of inhaled bronchodilator with more than 12%. And then we have blood investigation. Full blood count, usually we will see eosinophilia in asthmatic patients and also leukocytosis in infective exacerbation. And then arterial blood gas. Um, we need to know either the patient is hypoxemia because patient will be hypoxemia if the asthma develop complication like type 1 respiratory failure. And then we can look for the chest X-ray in asthmatic patients. It will show hyperinflated lung, but other than that, we also can rule out other diagnoses such as pneumonia and so on. And last, we can do skin prick test to identify the trigger of the exacerbation. And then next slide, principal management. First, we need to assess the asthma severity or newly diagnosed asthma, and then choose preventive treatment, and then assess the asthma control in 4 to 8 weeks, and then do a stepwise medication and also monitor asthma control. Next slide. Okay. This is the evaluation for newly diagnosed asthma. For newly diagnosed asthma, we have intermittent asthma or persistent asthma. And for persistent asthma, we have mild persistent, moderate persistent, and also severe persistent. Um, for intermittent asthma, the patient will having daytime symptoms less than once a week, nocturnal symptoms less than twice a week, and then no exercise-induced symptoms. Breath exacerbation will not affecting sleep and activity. For mild persistent asthma, the patient will have daytime symptoms once a week, more than once a week, and then nocturnal symptoms more than twice a week, twice a month. I'm sorry. Okay, exacerbation will affect the sleep and activity once a month. And then the peak expiratory flow rate and or FEV1 will more than 80%. And the exercise or activity, uh, there will be exercise or activity induced asthma. For moderate persistent asthma, uh, the, they will have daytime symptoms daily, nocturnal symptoms more than once a week, exacerbation affecting sleep and activities more than twice per month, and then PEFR or FEV1 between 60 and 80%. Exercise or activity, there is exercise or activity induced asthma. And for severe persistent asthma, um, the patient will have daily daytime symptoms, daily nocturnal symptoms, exacerbation affecting sleep and activity frequently, PEFR or FEV1 less than 50%, and the exercise or activity will induce asthma. Next slide. This is the 9 parameters of assessment of severity of acute asthma exacerbation. As I mentioned before, that we need to ask in this history. So we need to the mnemonic uh, if we can remember worst guess, which is W for wheezing, or O for oxygen saturation, R for respiratory rate, S for C, T for tachycardia or bradycardia, G for GCS, A for accessory muscle use, S for SOB when, and also P for PEFR percent. So you guys can see here how to know either the patient has mild, moderate, or severe exacerbation or life-threatening exacerbation. Next, next slide. Okay. This is the acute management for um, bronchial asthma. If the patient comes with mild asthma, we need to nebulize the patient, uh, and then nebulize salbutamol or NDI salbutamol. Sorry, um, nebulize the patient. If the patient has improvement after within 20 minutes, we need to observe in 60 minutes after that. So if the patient is still okay, we need to discharge the patient with improved long-term treatment and asthma action plan, short course of oral steroid, regular bronchodilator, 5 to 6 hours for a few days, and then early TCA within 2 to 4 weeks. But if the symptoms have have no improvement within 20 minutes, we need to treat them as moderate uh, asthma, which is we need to nebulize to them back and with cipratopium bromide and oxygen at 8 liter per minute via face mask. And then observe if there is improvement, we will manage to same with mild asthma. But if there is no improvement, we need to um, admit the patient and give um, and manage as listed here. Nebulized with oxygen, IV corticosteroid, and so on. And then continue observe and also review the patient. Next slide. So this is the complications for bronchial asthma, which is patient with asthma can complicate with pneumonia, lung collapse, type 1 respiratory failure, like I said before, when the patient has hypoxemia, and also pneumothorax. That's all for me. Thank you. Is there any question?
Okay, any questions? I mean, asthma is quite straightforward lah. You guys should be quite used to the disease already kan. Kat ward pun banyak cases of asthma. Get to see a lot of asthma cases. Any questions? Okay, kalau tak ada soalan, kita proceed to the next title.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So, my name is Nifarina Samidin Azan. So, I will be presenting regarding bronchiolitis. Next. So, what I will present today on the topic of bronchiolitis are first the introduction, and then the causes and pathophysiology. What are the clinical features presented by the patient come with bronchiolitis, the complication, the investigation, division diagnosis, and also the outline of the management. Next. So first, as the introduction, so by definition, bronchiolitis is an inflammation of the small airways in the lungs. We call as the bronchioles. Then it is the commonest serious lower respiratory tract infections of the infants aged 1 to 6 months old. And the annual peaks for bronchiolitis are in November, December, and January, which are in the winter season. The risk factors for bronchiolitis are first the premature infants, second infants less than 6 months old, then children less than 2 years old with chronic lung disease or congenital heart disease, children with weakened immune system, and also children with who have neuromuscular disorder. Next. Second is causes and pathophysiology. So the most common cause of bronchiolitis is respiratory syncytial virus, which is the single-stranded RNA. Other viruses that can cause bronchiolitis are adenovirus, rhinovirus, myxovirus, and also human beta pneumovirus. And the example of bacteria that can cause bronchiolitis is Chlamydia trachomatis. Next. So how does bronchiolitis happen? So there are 4 changes happen in bronchiolitis. The first one is there will be narrowing of the airway due to mucus hypersecretion. Second, there will be cell wall thickening. Third, there will be small muscle contraction, and fourth, there will be air trapping. So when the virus get into the respiratory system, it will replicate in the nasopharynx, then eventually it will go to the bronchioles, the smallest airways before it goes to the alveolus. So when this happens, lower respiratory infection will occur, and this will cause inflammatory responses in which the immune cell will infiltrate the area, and these inflammatory responses will cause edema. So there will be increased mucus secretion produced by the goblet cells in the epithelium. And eventually there will be necrosis and also regeneration of the epithelial cells. So all this pathophysiology will lead to small airways obstruction, and there will be air trapping and increased airway resistance. So all this what we call all these things will lead to signs and symptoms in bronchiolitis. So I will repeat again. In bronchiolitis, there will be few changes. The first one is there will be narrowing of the airway due to high mucus hypersecretion produced by the goblet cells. Second, there will be cell wall thickening because there is regeneration of the epithelial cells. Third, there will be small muscle contraction, and fourth, there will be air trapping. Means when the patient breathe in, the air goes into the alveoli, but because of there is increased resistance, so the air cannot go out. So the air trapped in the alveolus. Okay, next. Okay, so what are the clinical features that will be presented by a patient comes with bronchiolitis? There are three most common symptoms. The first one is coryza symptoms, means the patient will come with nasal congestion, runny nose, and mild cough. Second, there will be low grade fever and there will be cough. Other symptoms shortness of breath, wheezing, apnea, and irritability. So for the signs in bronchiolitis, the patient may be tachypneic, there will be subcostal and intercostal recession, as you can see in the picture beside the table. There will be hyperinflated chest. On auscultation, we may hear fine crepitation in onkai, and if the condition of the patient is severe enough, the patient may develop cyanosis. Next. So what are the complications in bronchiolitis? First, apnea. As we know, apnea is when the patient breathes, when the patient breathing suddenly stop and restart when they are sleeping. So this is because of the narrowing of the small airways. Second, patient with bronchiolitis may develop bronchial asthma eventually. Third, there will be recurrent infection, and fourth, there will be otitis media. Acute otitis media is the most common bacterial co-infection of viral bronchiolitis. Okay, next. So what are the investigation in bronchiolitis? Actually, there is no specific investigation that we can do to confirm the bronchiolitis diagnosis, because it is solely based on the clinical judgment. But I mean, based on the history of presenting illness and also from the physical examination that we do. But there may be some investigation that we can do to rule out other differential diagnosis. The first one, blood investigation for blood count. There may be leukocytosis because of the infection. And second, maybe we can do ABG to look for the SpO2 level of the patient, especially if patient is having shortness of breath. Then imaging, we can do chest X-ray. In bronchiolitis patient, there may be hyperinflated of the lungs, flattened diaphragm, and maybe we can check for consolidation to rule out pneumonia. The third one is nasopharyngeal swab. We can do virus culture and serology, and also immunofluorescence antibody. Next. So what are the differential diagnoses for bronchiolitis? First is bronchial asthma, as Sister Dina has presented before. Then she mentioned that in bronchial asthma, usually patient will not have fever like bronchiolitis. Second is viral induced wheeze. Third is pneumonia, and fourth one is pertussis, or we call as whooping cough. If we want to rule out pertussis, maybe we can focus more on the characteristic of the cough presented by the patient. Next. So what is the outline of the management? First, patient usually come with rapid breathing or shortness of breath. So first, we have to resuscitate the patient. So if the patient is tachypneic or patient is SpO2 level is go down, we need to give oxygen support. Second, we need to give feeding and fluid therapy, because infants that admitted with viral bronchiolitis usually have poor feeding, so they will be at risk of aspiration and may be dehydrated. So we need to feed and give fluid therapy to the infants. And the last one is pharmacotherapy. We can give a nebulized 3% saline solution. It will increase mucus clearance. Then maybe we can give inhaled beta-2 agonist, or inhaled steroid, but inhaled steroid doesn't give much or any benefit actually. And the last one is antibiotics. But for antibiotics, it's recommended for all infant with if the infant have recurrent apnea or possibility of septicemia, or there may be acute clinical deterioration or high white cell count, then we can give antibiotics to the patient. Next. Okay, I think that's all from me regarding bronchitis. Is there any question?
Ada soalan? Kalau tak ada soalan ataupun nak simpan soalan at the end pun boleh. So kita proceed to the next topic lah.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I will represent about the next topic, which is pneumonia. So this is the table of the contents that I will discuss about, which is number 1 is introduction, the etiologies of the pneumonia and the pathophysiology of pneumonia, signs and symptoms, investigations, complications, and the management of pneumonia. So for introduction, so the definition of pneumonia is infections of the lung parenchyma with consolidation of the alveolar spaces. So we can see in this picture below. So we can see there is this is the upper one is the normal alveoli, and the below one is the there is consolidation at the alveolar spaces, which is we can say about other pneumonia. So for the epidemiology, pneumonia is the single largest infectious cause of death in children worldwide. So according to WHO, pneumonia has killed about 740,180 children under the age of 5 in 2019 alone. But the pneumonia can occur at any age, but the highest incidence rate is in infants and in preschools. So this is the etiologies of pneumonia. Pneumonia can be caused by bacterial and also can be caused by viral pathogens. For the bacterial pathogens, so we can classify it through the age, such as if the patient is newborns. So the predominant punya bacterial pathogens would be group B Streptococcus, E. coli, Klebsiella species, and Enterobacteriaceae. And in the age of infants of 1 to 3 months old, the most likely would be the Chlamydia trachomatis. And during the preschool age, it can be Streptococcus pneumoniae, Haemophilus influenza type B, Staphylococcus aureus. But also in the preschool age, it will be less common to be a group A Streptococcus, Moraxella, or Pseudomonas. So in the school age, usually it will be the Mycoplasma pneumonia or Chlamydia pneumonia. For the common viral pathogens, usually it is caused by the respiratory syncytial virus, influenza A or B, adenovirus, or parainfluenza virus. So the pathophysiology of the pneumonia, there is a few how the mechanism of each pathogens works, such as there is inhibition of resident alveolar macrophage phagocytosis. If the patient have immunodeficiency such as HIV or cancer, repressed cough reflex, or there is any infiltration to the mucociliary of the cells, which can cause mucociliary impairment. And these factors can cause local and systemic defenses, failure of the local and systemic defenses. So the pathogens will infiltrate and proliferate in the alveoli, which will cause the immune system to be triggered. And due to the immune system being triggered, there will be inflammation at the alveolar or the interstitial. And due to this inflammation, the alveoli become leaky, and the there will be leaky alveolar walls and pulmonary capillaries. The alveoli will fill with fluid, pro-inflammatory molecules, and blood cells and possible pathogens also in the alveoli. And this would cause there will be a gas exchange impairment in the patient. So for the symptoms of pneumonia is most likely the same as bronchiolitis, such as represented by Sister Karinisa. So usually the patient may come with fever. This fever the patient may have with or without fever. Cough in this is maybe in smaller children. Maybe the patient could not cannot pick out the sputum, so it can be chesty in nature, but sometimes the cough can be productive. There will be breathlessness, but the most common punya presentation of the pneumonia is rapid and shallow breathing. So other than that, there is runny nose. Sometimes patient will look toxic looking, or we can call as lethargy, restless, agitated, and irritated. And sometimes the patient may have a pleuritic chest pain, which indicate there is pleural inflammation. For the physical findings, so during the inspection, we can see the patient is tachypnea. Maybe the patient have a grunting sound. So later I will show you also about the grunting sound. And hunger, which patient would looks like to be breathlessness, nasal flaring, toxic looking, which is more likely to be lethargy, recession, such as Sister Karinisa has talked about. And the palpation will be, there will be reduced chest expansion. And on percussion, there will be dullness due to there is fluid in the lungs. And auscultation, we can hear bronchial breath sound, and there will be coarse crepitations. So this is the grunting. First, I will show about the grunting group. Okay, yang tu bunyi grunting in in baby if patient have respiratory distress, and this is video about chest recession yang like Sister Karinisa has talked about.
Children who are experiencing difficulty breathing may sometimes suck the skin into their chest. This often occurs below the rib cage or at the neck.
Okay, so the next one is flare nostril. We can see at the left side, this is the normal nostril, and the left side and the right side is flare nostril. So in pneumonia, we can assess the severity of the pneumonia. So this is, the table is being taken in our PITS protocol 4th edition. So in the children below 2 months old, there is severe pneumonia. For in this severe pneumonia, we can see there is severe chest indrawing and tachypnea. For the very severe pneumonia, the patient may come with not feeding, convulsions, sometimes abnormally sleepy, difficult to wake up, fever, or hypothermia. In the patient in the age of 2 months to 5 years, for mild pneumonia, the patient may come with tachypnea only. And severe pneumonia, there will be chest indrawing, and the very severe pneumonia, the patient might not be able to drink. There will be convulsions, and the patient may have increased drowsy, increased sleepiness, and maybe there is malnutrition. So tachypnea is defined as follows, such as we can classify age below than 2 months age. Tachypnea is more than 60 rates per minute. For the age of 2 to 12 months, the rate is about 50 rate, more than 50 rate per minute. And for the age of 12 months to 5 years, the rate is about more than 40 per minute. So there is the tachypnea, which is for the inpatient, according to according to Pitt's Protocol punya 4th edition. So for investigation, in this investigation, we can use then upper chest X-ray. For the chest X-ray, there will be evidence of consolidation, which can conclude may suggest to pneumonia. And sometimes in chest X-ray also we can see pleural effusions or empyema. And in the pool blood count, there will be increased count with predominance polymorphonuclear cells, which may suggest there is bacteria in nature, but and there will be also leukopenia and it may suggest the cause of the pneumonia is viral. For blood culture, this is a gold standard to determine the etiology of the pneumonia. So this is very important to know what we want to give antibiotics to the patient. For the pleural fluid, if there is significant pleural effusion, we can use pleural fluid analysis to find the cause of the pneumonia. And we can also do serological tests if we suspected atypical pneumonia. So there is a few complications that can be caused by pneumonia, such as parapneumonic effusions. So parapneumonic effusions is accumulations of fluid at the pleural space adjacent to the pneumonia lah. So and also the empyema. So we can see there is a collection of pus in the pleural space, and it can be either adjacent to the pneumonia or other causes such as trauma. And this parapneumonic effusions empyema is commonly seen in patients with Staphylococcus aureus infection, Streptococcus pneumonia, and Streptococcus pyogenes. And patients sometimes can develop lung abscess due to lung abscess. If the patient can develop a lung abscess, sometimes if the pathogens is spread through hematogenous spreads, and the patient may have septicemia. So for the management, there is a criteria for hospitalization for pneumonia. So the children aged 3 months and below, regardless of severity. If the patient has fever more than 38.5 degrees Celsius, which is high grade, and there is refusal to feed and vomiting, fast breathing with or without cyanosis, associated systemic manifestation, and patient with failure of previous antibiotic therapy, recurrent pneumonia, or patient with severe underlying disorder such as immunodeficiency. So for the inpatient management for children with severe pneumonia, we can give antibiotics. So the first line antibiotics to treat pneumonia is beta-lactams, which is benzypenicillin, moxicillin. But if there is if the first line is, if the patient is not respond to the first line antibiotics, we can start on second line, which is the cephalosporins. The third line will be the carbapenem and other agents such as aminoglycosides. And if the patient is suspected to be infected by mycoplasma or chlamydia, we can give microlides to the patient. For the outpatient management, so outpatient is for children with mild pneumonia, and they usually have fast breathing with no chest indrawing. So we can prescribe oral antibiotics according to the pathogens, macam in this table below, which is Streptococcus pneumonia, we can give penicillin and cephalosporin. Haemophilus influenza type B, we can give ampicillin, and other organisms such as mycoplasma, chlamydia, and bordetella, we can give macrolides. So also in outpatient management, we must educate parents on how to manage the fever, ways to prevent the dehydration, and identify signs of deteriorations. So if the patient's condition is worsening, so the patient may come for a return for the reassessment. I think that's all for my pneumonia. I will pass to the, if there any question, or I will pass to the next presenter.
Continue to the next presenter dulu lah.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I am Salsa binti Saidin and I will present about acute gastroenteritis and dehydration. Okay, on this slide, I have listed the contents, which are introduction of the disease, the pathophysiology, clinical features, complication, and appropriate investigation regarding the disease, differential diagnosis, and the management of the disease. So the first one is introduction. We start with its definition. Gastroenteritis is inflammation of stomach and intestine. So it will increase in stool frequency with alteration in stool consistency, but it needs to be abrupt onset of 3 or more loose stool per day. So if you wonder what's the difference between acute or chronic gastroenteritis, then the answer is acute gastroenteritis is lasts no longer than 14 days, which is less than 2 weeks duration, while chronic or persistent diarrhea is defined as an episode that lasts longer than 14 days, which is more than 2 weeks duration. So for epidemiology, the acute gastroenteritis is a leading cause of childhood morbidity and mortality and an important cause of malnutrition. It is also related to malnutrition, poor hygiene, poor socioeconomic status, education level, and bottle feeding. So we need to ask this kind of question like how their mother wash her daughter or children's bottle. So the next one is the etiology. It can be from virus, bacteria, protozoa, and parasite. From the virus, the rotavirus is the most common. That's the picture of rotavirus. I'll put the picture. And then the next one is adenovirus, which is type 40 and 41. The next one is norovirus, or we can call norovirus, astrovirus, coronavirus, pararotavirus. For bacteria, it can be categorized into enteroinvasive and enterotoxigenic. For enteroinvasive, it can cause bloody diarrhea. So the bacteria that can cause bloody diarrhea is Campylobacter jejuni, which is the commonest, Shigella, Salmonella, Enteropathogenic E. coli, and Yersinia. While for enterotoxigenic, it can cause watery diarrhea. And then watery diarrhea, it can cause by Vibrio cholera, Enterotoxigenic E. coli, Bacillus cereus, Clostridium perfringens, and difficile. And the last one is the Staphylococcus aureus. For protozoa, there's 3 organisms, which is Giardia duodenalis, Cryptosporidium, and Amoeba histolytica. And the last one is parasite. For parasite, it can be because of Entamoeba histolytica, Giardia lambda, Cryptosporidium species, and the last one is Cyclospora aetenesis. So the next one is pathophysiology. Diarrhea occurs when intestinal fluid outputs overwhelms the absorptive capacity of the gastrointestinal tract. So, so there is 2 primary mechanisms. The first mechanism is it can cause damage to the villus brush border of intestine, and this can cause malabsorption of intestinal contents and leading to osmotic diarrhea. For the second mechanism, it can release of toxin that bind to specific enterocyte receptors, causing release of chloride ions into the intestinal lumen and leading to secretory diarrhea. So the next slide shows the clinical features of acute gastroenteritis. There is a typical presentation of acute gastroenteritis, which are diarrhea and vomiting. You can look at the bright box orange at the left side. So if there's diarrhea, it has to be acute onset, lasts for 5 to 7 days, still typically loose or watery. There is increased stool frequency, fluidity, and volume compared to normal stool. And then the content, it can be greenish, mucus, blood, musty color, and if this sign occur, then it means it is invasive bacterial infection. The next typical presentation is vomiting. So it needs to be acute onset and is usually lasts for 1 to 2 days. There's additional presentation, for example, fever, lethargy, dizziness, abdominal pain or cramps, nausea, loss of weight, headache, myalgia, reduced urine output. And we also need to ask about the historical features, which is travel history, exposure to the food like raw food or uncooked. And then the farm animals, and the last one is social history. So there's also physical findings. We need to look at the abdomen. It will be soft and voluntary guarding may present. Mild to moderate tenderness on palpation, and there will be sign of dehydration. I will explain the sign of dehydration again on the next slide. And we need to also look at the red flags when the patient comes with diarrhea and vomiting. For example, we need to look at dry mouth or dry mucous membranes, bilious or bloody vomiting, decreased skin turgor, altered mental status, tachycardia, tachypnea, which is the sign of acidosis, persistent diarrhea, which is more than 10 days, hypotonia and weakness, which is the sign of hypokalemia, bloody stools, coma, convulsions, and comorbidities such as HIV and diabetes. Okay, this is the clinical features of dehydration. So we need to be able to assess the hydration status of the patient. So we can start with general condition. If the patient came with mild, so the general condition will be he or she will be alert and responsive. The anterior fontanelle, if it is baby less than 6 years, surely we can see anterior fontanelle. So the anterior fontanelle is normal, not depressed or sunken. The eyes is not sunken, tears normal, tongue is normal, mucous membrane is still moist, skin pinch test or skin rigidity. When we pinch at the abdomen side, the skin goes back immediately, which is we call instant recall. And the breathing is the normal, blood pressure is normal, urine is decreased and concentrated. And if we offer the child fluid, so the child will drink normally. While for moderate, the general condition is we can see that children is lethargic and irritable. The anterior fontanelle is depressed, the eyes is sunken, tears is decreased, tongue is dry, and as well as mucous membrane. The skin pinch test is it is mildly decreased, so the skin will return slowly, and the breathing is increased, but the blood pressure is still normal, and the urine is markedly decreased. Because this is dehydration, right? So of course the urine will decrease. And if we offer the child fluid to drink, so the child will drink eagerly or thirsty. But for the severe condition of dehydration, the general condition, they might reduce conscious state or in coma. Anterior fontanelle is markedly depressed, the eyes is deeply sunken, the chest is absent even though the baby is crying, the tongue is very dry, fur, mucous membrane is dry, skin pinch test, the skin goes back very slowly, more than 2 seconds, and it's like tanking. We will look at that later. And the breathing, it is increased because like the deep acidotic breathing. The blood pressure is hypotension, and the urine output is very little, scanty, or no, which is oliguria or anuria. If we offer the child fluid, he or she is not able to drink or drinks poorly. That's it, the lethargy. So these are the pictures of the dehydrated baby. So you can look at the bottom of the right slide. This shows the very sunken eyes and very dehydrated and lethargy baby. And the next picture is anterior fontanelle, which is deeply sunken. And you can look at the picture with it explains much of the symptoms of dehydration. And if you look at the left bottom of the slide, you can see the tanking. The skin pinch test is which is severe. So the next one is complication of the disease. If it involves brain, which is CNS, so the convulsions will take place, febrile convulsion, and it is usually associated with tubular infection. The other organ that can be affected is GIT, gastrointestinal tract. So they will have prolonged diarrhea, which is more than 14 days, and the other organ is renal. So they can complicated with oliguria, hypovolemic shock, electrolyte imbalance, metabolic acidosis, renal venous thrombosis, and HUS, hemolytic uremic syndrome. Additional information is many diarrhea deaths are caused by dehydration and electrolyte loss. So it is important to us to assess the dehydration status of the patient. So the next one is investigation. We can classify the test into three major components, which are blood, stool, and others. The stool is the confirmatory investigation for the disease. So the blood, we can do full blood count to look for leukocytosis, blood urea and serum electrolytes, and creatinine for dehydration and electrolyte imbalance. So from this test, we can assess the electrolyte, either it is hypo or hypernatremia or hypochloremia. We can also look for blood urea nitrogen bind. The creatinine will be disproportionate high in severe dehydration. The serum bicarbonate, it can be low in metabolic acidosis, and random blood sugar, it shows for intake results in relative hypoglycemia. The next one is stool investigation. So we can do the stool for rotavirus antigen, which I have mentioned that rotavirus is the most common virus that can cause acute gastroenteritis. And then the next one is to culture and sensitivity, for example, for Salmonella, Shigella, Yersinia, Campylobacter. And the next one is to red cells and leukocytes. And the last one is to ova and cysts for parasites. And others is you can do ABG, the metabolic acidosis, because metabolic acidosis is one of the complications. And the next one is urine osmolality, which is it will be increased in dehydration. So the next one is management. The next one is the differential diagnosis. Yeah, differential diagnosis. So it can be from if it's a systemic infection, we can suspect septicemia or meningitis. If local infection, we can suspect respiratory infection, vitis media, UTI, and hepatitis A. For surgical cause, there could be because of thyroid stenosis, interception, acute appendicitis, necrotizing enterocolitis, and H1 disease. And the next one is if it is metabolic disorder, we can suspect diabetic ketoacidosis, and if it is from renal, maybe it can cause because of hemolytic uremic syndrome. And the others, celiac disease, lactose intolerance, cow's milk protein intolerance, and adrenal insufficiency. So, okay, the last one is management. So, what we need to look for is we need to assess child's general condition, look for sunken eyes, and we need to try offer the child fluid, and we need to do pinch skin of abdomen. So I have explained this in dehydration, how to look for dehydration status. So if the patient is well, alert, no sunken eyes, drinks normally, skin goes back immediately. So this is the sign of mild dehydration. So we need to treat with plan A, which is we give fluid and food to treat diarrhea at home. And the next one is if the child is restless or irritable, sunken eyes, drinks eagerly, or she looks thirsty, the skin goes back slowly. So this is the classification of moderate dehydration. So we need to treat with plan B, which is we give fluid and food for some dehydration. And the last one is if the patient looks lethargy or unconscious and has sunken eyes, not able to drink or drink poorly, the skin goes back very slowly, more than 2 seconds. So this is a sign of severe dehydration. So we need to treat with plan C, which is we give fluid for severe dehydration and provide food as soon as the child can tolerate. So yeah, this is the indications for hospital admissions. So what type of that hospitals? If the patient comes with short or severe dehydration and there is persistent or bilious vomiting, even if there's no sign of dehydration, if the patient is failed ORS treatment and clinical deterioration or neurological abnormalities such as lethargy or seizures, then the patient's vitals itself, which if the patient has underlying medical conditions and then other possible illness. And the last one is if the caregiver not able to provide sufficient care at home, so we need to treat at the hospital. And the age-appropriate diet recommended after rehydration. So antibiotics not used routinely, only helpful in cases of bloody diarrhea and suspected cholera with severe dehydrations. And anti-diarrhea medications not routinely suggested, and the zinc supplements recommended during acute episode of diarrhea for children above 6 months and above. So this can be in areas with high prevalence of zinc deficiency and malnutrition. And addition information, the dehydration can be safely and effectively treated with ORS, but if the severe dehydration, it may require intravenous feed therapy. So this is the references from protocol page. Okay, thank you.
Okay, thank you to all the presenters. Do you have any questions tak? I think all this acute respiratory illness ni quite a straightforward topic lah kan. I mean the diagnosis sometimes can be difficult lah. Some ada dia tak tahu nak make diagnosis whether this is acute bronchiolitis ke, whether this is pneumonia ke, whether this is asthma ke. Some people might, kalau you tengok ada orang buat diagnosis macam ni, ada orang buat diagnosis macam ni, actually it the relevance is very little lah. I mean not much relevance. Yang pentingnya you tahu nak assess the degree of respiratory distress tu, and then when you should worry lah, maksudnya child ni ada signs of severe illness, you have to act quickly lah kan. So the diagnosis at the time doesn't matter whether this is asthma ke, bronchiolitis ke, pneumonia ke, but if the child is in severe respiratory distress, need treatment, need oxygen, need ventilatory support, needs patient in shock ke kan, so you have to act on that. So the diagnosis tu is secondary lah sebenarnya. So kalau patient dengan respiratory illness datang dengan very severe, I mean it can be just bronchiolitis je, but sometimes it's not wrong kalau in the beginning tu kalau you nak start antibiotics dulu, empirically to cover dulu kan, because you're not sure whether this is a bacterial or a viral. So a lot of the time it can be multi pathogen, tak semestinya satu pathogen saja involved kan. So usually the severe cases, sometimes they have more than one pathogen involved, whether it's viral or viral bacterial kan. So maybe it's initially a viral and then they ada superimposed bacterial on top of that, so they become severe. So it's not wrong to start antibiotic walaupun you tengok diagnosis the acute bronchiolitis, tapi sometimes we do start antibiotic because patient came in very ill, dehydrated, memang ada signs of systemic punya involvement lah. So when patient ada signs of systemic involvement tu, we are more worried about bacteria which can progress more quickly into more complications, so we act on it. So kalau it's a viral lah kan, I mean you can downgrade your antibiotics later when katalah you dah hantar blood culture ke, CRP ke, ataupun you punya serology or respiratory viruses punya PCR came out as negative or viral illness, then you can downgrade your antibiotics or off your antibiotics lah. But the initial treatment tu is very important untuk support dulu whatever the diagnosis is. So because you can revise your diagnosis later. Okay. Any questions? So AGE is quite straightforward lah. You have to recognize the degree of dehydration. You kena tahu how to assess degree of dehydration very quickly lah, because you have to act kalau patient in shock ke. Okay. Ada soalan tak? Tak ada soalan? Okay. Kalau tak ada soalan, kita boleh tamatkan kita punya session CME hari ini. Nanti one of you guys message me lah untuk dia punya, untuk the marks you punya nama dengan nama full name semua untuk marks you. Okay, boleh bersurai lah.
Thank you, Dr.
Thank you, Doctor.
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 And presenters.
Thank you, Doctor.